Hi, everyone. Victoria here with a quick note before the acetaminophen episode. So this episode and the episode that comes directly after it on vaccines and vaccine schedules, and I have discussed it, and we want to make both of these episodes open access. So they will not be behind a paywall. Everyone will have access to them. Normally, our paid subscribers get an extra episode every month. Don't worry if you are a paid subscriber. We have lots of good content coming next month for you. But with these topics being so timely and so crucial, we want everyone to have access to Bob Block. He's a pharmacist that was on for the ivermectin episode. He's back to talk about acetaminophen. He's a clinical pharmacologist. And then in the vaccine and the vaccine schedule episode, we speak with immunologist Dr. Heather Zwicky. So we just feel like everyone deserves their balanced takes. They have a really deep understanding of the research literature on both of these topics. They work clinically, so they actually work with people. They have really, really excellent information to share, and everyone deserves to have access to that right now. So if you have questions, if you have friends or family that have questions, please share this episode with them. Listen to this episode. Like I said, really good at-home takes. So stuff that you can actually use. We do talk about the research literature, but it's not just theoretical. We have good application that we share. If you have questions, please email me, influencetodeath@gmail.com. Thanks. Welcome to Influence to Death, your guide for navigating the wild world of wellness influencing. Hi, and welcome to Influence to Death. My name is Victoria Lafont, and today we actually have a guest host and then another special guest back with us again. So Amanda Jones is here as guest host. Hannah is in the middle of getting her MPH, and between that and chasing around her little guy, I think she might take a little bit of time off, and Amanda is going to be here a little bit more. And then we have asked pharmacist Bob Block back on today. So he was just here for the ivermectin episode. And this is a special episode that we are filming about acetaminophen. Maybe you have the grand luck of living under a rock, but if not, you probably have noticed that acetaminophen or Tylenol has been in the media more lately. So we wanted a really educated, informed person to come and talk to us about that. So I know Amanda's been on the podcast a few times. Bob, you've been here, but would you all just kind of briefly introduce yourselves again if people haven't listened to those episodes?
Yeah, I'll jump in really quick. I am more on the nutrition side of things. My master's is in human nutrition and functional medicine, just like Victoria. I'm an instructor at the Nutritional Therapy Association, and I focus a lot on digestion and blood sugar regulation, and have had years of clinical practice as well, but these days I'm pretty busy in the classroom. So I do try to work with people still a little bit just to keep my information grounded in the real world rather than it all just being theoretical, mental jibber jabber. It always helps to work with real humans, but for the most part, I teach, and it gives me a great opportunity to just do continued learning and continued research and trying to keep up with my students because they're always coming in with new information too. They got the hunger, so...
And I want to make sure people know, Amanda, you have a lot of depth in research around cognitive health. I think both men and women, right? But that's a big part of your focus is that you're creating curriculum around, is cognitive health, does that cover it?
Yeah, well, I'm specifically preventing cognitive decline and even more specifically for ApoE4 carriers, preventing Alzheimer's disease through early diet and lifestyle intervention. My maternal line is riddled with Alzheimer's disease, and I know I'm an ApoE4 carrier. I have one copy, so I've taken quite an interest in starting now to start doing everything I can to kind of mitigate some of the adverse changes that come with that gene variant and protect my aging brain. Yeah, and I will also
an article on Alzheimer's in women before we got started. I didn't realize that most Alzheimer's patients are female.
2 out of 3, yeah. And there's a lot of reasons probably for that, interrelated complex reasons. I'll just also share too, as kind of like pertaining to today's discussion, that I'm also a new mother at 41. Wait, I'm actually 42 now, but I became a new mother at 41. And so I have an 19-month-old son. And so I was down the rabbit hole of like, of all the medications and all of the, different publications around the acetaminophen and safety in pregnancy quite recently. Not not to suggest that I have a really great handle on the research, because I think that it takes a lot of attention to really get a good handle on it, but I do have a significant amount of empathy and understanding of what it feels like. I have a fresh sense of what it feels like to be an expecting mother and worried about the health of the fetus and the child. So I can bring that to the conversation today as well.
Awesome.
And I'm Bob Block. I'm a clinical pharmacist. I work primarily in the inpatient setting, taking care of hospitalized patients. And so I see kind of what brings them in, what medications that we put them on or take them off of, dosing those medications correctly, and treating their conditions and getting them out of the hospital faster.
Yay. We appreciate your service, Bob.
Oh, of course.
Bob, can I ask you something really quick? Much of your work, how much are you pulling in genomics?
So we are. Yeah, it's an exciting field, as you know. We use it a fair bit when we pick like antiplatelet agents for like stroke prevention and after someone gets like a PCI inserted in their heart. So we use that to help make sure that they're on the correct medication. We also do the genetic testing for the genetic linked diseases. We use it a fair bit for like von Willebrand's disease, factor V lesion mutations, that sort of thing. I primarily work with cardiac renal patients, so that's where I personally see it a lot more. But we have an entire women's hospital where they work with that much, much more in depth.
And I should say, for anybody listening that doesn't know kind of where that question came from, I think it relates to today's topic because our genetics influence our ability to metabolize medications in really profound ways and can influence how safe or toxic they are for us and how likely we are to have adverse reactions, right? And so that's kind of an up and coming area as using more, genetic sequencing before administering some types of medications to better predict what somebody's response will be and how safe they will be for that individual. Is that a good?
It is. So certain medication therapies are ideal for patients or won't work at all for patients depending on their genetic factors. And so they might metabolize a drug very, very quickly and we just need to increase the dose of it, or they might not metabolize it at all and we either need to decrease the dose or we need to avoid it altogether because it can build up the toxic levels. Or in the case of Plavix, clopidogrel, it's actually a prodrug. It's converted in the body into the active form of the medication. So if someone is deficient in those enzymes, that genetic linked metabolism, they actually don't get any benefit from that medication. So we use it kind of on multiple angles of making sure that drug therapy is safe and effective.
Yeah. And in that vein, I wonder if we're collaborating on this conversation. We do have a reference document that we're pulling from, but Amanda, I feel like that's such a good question. I wonder if we should just start and kind of lay out the land of like, here's what acetaminophen is and here's how it's metabolized. And I think, I know Amanda, you've like brought the juice with you here. The research that you've done. I know Bob's going to have great information on this, but just to kind of explain to people the process of biotransformation that happens in the body so that our body is able to metabolize its drugs, the food that we eat, anything that we're exposed to through oral or our respiratory systems. Our body has a way of metabolizing that. And I think we think of metabolism as kind of like, well, I think people think actually when they hear metabolism, they think I'm either like gaining weight or not. I think that's where people's minds go.
Right.
But and I'm going to take a stab at this. And I think both of you are, as I said earlier, adultier adults than I am on this topic. But when we talk about metabolism, it's essentially a transformation in our bodies of one thing into another. So that might be a drug into an intermediary that then we have to metabolize again to get out. It might be food into biochemical components to create ATP. Metabolism happens in many, many biochemical reactions. So the main metabolism we're talking about today in this context is acetaminophen. Is that right?
Yeah.
Question mark.
Yeah, it's
Yeah.
such an expansive word. I mean, it's everything that the body does to stay alive and maintain homeostasis, basically. It's just like
Yeah.
like,
So
yeah.
with acetaminophen, I mean, Bob, do you kind of want to take like, I mean, I've read a little bit about it, like to the point where I'm like, wow, I didn't realize we're not even sure what the
Mhm.
mechanism of action is. But do you want to speak to that a little bit?
So acetaminophen is a analgesic and antipyretic. You will often hear it mentioned alongside NSAIDs, which are nonsteroidal anti-inflammatories. It is not an NSAID. It
Hmm.
does not have anti-inflammatory properties. It does break fevers, or it can break fevers with the antipyretic effects. It does not actually directly reduce inflammation.
Right. And so antipyretic just means anti-fever.
Anti-fever.
And then analgesic is pain relief. Would that be?
Mhm. And the way that the acetaminophen works is it inhibits the cyclooxygenase signaling pathways or the COX enzymes. And these are involved with pain responses and inflammation and getting that kind of reaction from the body from a negative stimulus like pain or being sick, something like that.
And do I understand it correctly that the fact that acetaminophen is not an NSAID makes it a unique candidate in terms of its ability to be used in certain medical situations where NSAIDs we know are not safe, including during pregnancy?
Yes. So our NSAIDs also have effects where they can inhibit like blood coagulation. So it can increase a bleeding risk. It can increase the risk, specifically in pregnancy, it can increase the risk of the placenta either not anchoring properly early in the pregnancy and increase the risk of it separating during the pregnancy. And it can also increase the risk of as the blood vessels are forming in the fetus, those being leaky and not being able to support the fetus as it grows.
People often see those effects like in their digestive system with NSAIDs, right? Like
Yep.
they talk about like higher risk of ulcer or
Mhm.
right, but in pregnancy it's like pronounced because there's this
Mhm.
other process happening.
Yeah. And then NSAIDs can also negatively affect the kidneys. They can cause acute kidney injuries and can contribute to progression of chronic kidney disease. So in our patients that are in our benefit group for the NSAIDs, it's great. If they're in one of these situations where, we're concerned about bleeding risk or about their kidney function, then we want to avoid those medications and do something different. And
Mhm.
typically acetaminophen or Tylenol is our best option. There's multiple options, but it's typically the number one on our list of what to do.
I think it's important. I think it's kind of evident why it's really important to have an antipyretic. I think, did I even say that right? A fever reducing medication, because we know that fever also poses real potential risk, maternal fetal risk, right, during pregnancy if it is elevated high enough, long enough. When I was looking at that's an obvious kind of risk benefit analysis that has to be done. Like, is the fever more dangerous or is the medication
Mhm.
more dangerous? But I also think it's important to note that like pain really matters. It's not just the like reducing the humane act of reducing suffering in a woman who has a migraine or some other potentially major pain disorder during pregnancy, but that pain itself that goes unmanaged can actually create complications in maternal physiology that impact the fetus. I don't know if you have ever read anything about that, but that just the idea that pain management actually really matters. It's not just to suck it up and deal with it kind of thing. It can have kind of a sequelae of other adverse effects, like if you're left in severe pain.
Absolutely. Because the pain, it can lead to hypertension, it can lead to increased heart rate, it can increase levels of cortisol and other stress hormones, and all of those can negatively affect developing fetus.
The thing that kind of keeps coming up for me is like, I don't want to get too far off the biochemical road that we're on, but maybe I haven't said this. And I know for me and Amanda, I'm going to make a guess. For Bob, I don't know really where you stand, but we have this thing at the podcast where it's like we talk about our biases. It's like when I think about this topic and what has been publicly, like basically like portrayed in the media is how I see it the past week. there was a press conference. It was President Trump, RFK, Marty Marquez, I believe is how do you pronounce his last name?
I think so.
So, do you know Amanda? Am I pronouncing his name right?
I don't know.
They gave this press conference on, I'm making sure that I'm pronouncing his name right. Macri, maybe is how you pronounce his name.
I think it is Macri.
Macri. They gave this press conference that's basically like linking autism. I mean, they're saying neurodevelopmental delays, and then they're using the word autism with maternal use of acetaminophen. And then they're presenting this possible solution in this drug, which we're going to cover lightly today, leucovorin. And Bob made some notes, in our reference document about leucovorin. And so, it's like I can feel inside of me, I'm like, wow, when I first see that, I'm like, maybe we're getting somewhere. Like, this is great. It's like in my like hippiest, crunchiest self, I'm like, I don't think women should take Tylenol in pregnancy. And great, we have this B vitamin derivative to address this issue that in my office, I saw tons of kids on the autism spectrum. So I also am really clear that it's not just this like one cause dysfunction, right? It's like it's extremely complex. So I just want to like put that out there that I think like sometimes I'll like post on social media or I'll talk to somebody about it. And I think they don't realize that this podcast, I mean, it's obviously influenced by Hannah and I's bias, which is why we say our bias. But it's like, I don't think that they realize that like we came maybe from that background or that I came from that background. And so it's like, the whole goal is to kind of push against to see what the most accurate balanced take is, especially for a situation like this, because as Amanda is bringing up, it's not that you just don't take Tylenol in pregnancy and then there's no autism. There's a really important reason to consider what these people are telling us, because a fever, for instance, in pregnancy may actually be more connected to risk of neurodevelopmental delays than the freaking acetaminophen that is getting all of the press. So I think it's like, that's a little bit of a complicated story to put out there, but I think it's important context to give people, because bias actually is harmful. And that's why we try to talk about it and bring a balanced take. And this is just one example with the fever. And then like you're saying, with prolonged pain, if women are experiencing that can be connected to adverse outcomes, possibly more than taking Tylenol. So again, I don't want to like throw us too far off, but that's the backstory.
Yeah, it's too easy for I think the public to feel like we're looking for a smoking gun, like the right, where you can just list so many different things that have been found to have some associative link to higher odds of having a child with some type of neurodegenerative disorder, but there's so many of those. Vitamin D levels, thyroid disorders, different types of environmental exposures, stress.
Inflammatory level in the mom.
Yeah, birthing. Then even if you are conceived in a time where there's greater maternal exposure to sunlight during the first trimester, they think that is associated with lower odds ratio. Metabolic conditions, there's so many things, and a lot of them have actually significantly higher odds ratios than acetaminophen exposure. So it's one of many things. It deserves to be looked at, which is what we're doing, but it is important to remember the risk factors and the potential. I shouldn't even say risk factors, because some of these we can't even call risk factors. We can just call
it's linked somehow.
Associated links. Yeah, we just can't forget the bigger picture. There's a lot of stuff going on.
Yeah,
and I think another important consideration, especially when people talk about the rates are going way up and going through the roof, we're actually paying attention now and evaluating children and adults for autism spectrum disorders. Whereas, in the 20, 30 years ago, the kid was just weird, or a problem maker, or just nonverbal. And that was it. That was the rest of their care.
Mm-hmm.
Now we're actually kind of paying attention to these people when historically they have been very marginalized and shut away. I mean, state hospitals used to be full of people that we would diagnosed with autism today.
Mm-hmm.
So there is this kind of, additionally, this question of, are the autism rates actually higher now, or are they better? Is autism better recognized?
Mm-hmm. Mm-hmm.
One of the things that I pointed at is left-handed rates. In around like 1900 and before, only about 2% of people admitted to being left-handed. And then once the stigma around being left-handed kind of went away, like in the 40s, it jumped up to like 12-14%.
Right. It was like
Interesting.
connected to like devil worship or something, right?
Yep.
Wow.
In Latin, right is dextro or dexterous, and left is sinister.
Oh.
So going back,
Wow.
even somewhat recently, being left-handed was associated with being a devil worshiper, with being evil, with being unclean. So when we stop stigmatizing being left-handed, suddenly people are left-handed.
Mm-hmm.
And I think it's people are willing to admit they're left-handed as opposed to they were not left-handed before.
Yeah.
Yeah, I feel like we can see that. Like, I mean, God, people being gay. It's like
Endured
people have
stuff.
been gay forever. Now they're just being gay because they're not being killed or, fired or whatever. Yeah, there's hilarious videos that this family makes, Bob. I don't know if you've ever seen them on Instagram, but they're actually in Kentucky at their mom's house, and they're like, here's my entire spoon collection, and it's like 50, I don't know, 100 different types of spoons, like all in their little, and they're like, autism didn't exist in the 1950s when she was born. And then it's like, and here's my tiny box collection. And it's like 50 different. She's like, obviously somewhere on the spectrum, your entire house is categorized by these like tiny collections of things. Yeah, I think it's a consideration that should be part of this conversation. I think my goal with this episode is that we do bring some balance for maybe people who are kind of like, I don't know what to believe. I do want to do the best for myself and my baby. I have maybe taken Tylenol while I'm pregnant, and now I'm in month 8 and I'm scared to death, or I'm scared and I don't want to take it and I'm in pain.
Mm-hmm.
Or I have a fever and I'm not going to take it. I mean, that was kind of the line of research that I went down, because it did seem like most of the research that I saw, especially with fever, I mean, it's like we're going to talk about some studies. You don't want to let a fever get too high. It looks like especially in the first or second trimester, because the risk of neurodevelopmental delays can go up. So maybe should we kind of keep going on the understanding of acetaminophen? We kind of know what it does, but then like, how does the body deal with it? I think
the metabolism. I think the metabolism is really important too, because I think it points to some of the potential confounding factors of kind of what could actually be happening. Is it direct, is there a direct neurotoxicity of the acetaminophen, or is there other dynamics with oxidative stress in the body that could be happening that could explain some of the associations we see? So yeah, and then we can look more at studies too. It's funny, both sides of this debate are like, we don't have enough evidence. That's the bottom line.
And then actual people are like, well, what do I
Yeah. Bob, do you want to run through? I mean, I certainly can give my my best shot at like a kind of high school level explanation of the metabolism and have you correct me, unless you want to take a stab at it first, and then I can ask some questions to dumb it down.
Well, we can do a little bit of both.
Okay.
So acetaminophen, like all drugs, are metabolized in the body. They are converted into compounds that are easier for the body to excrete. And most of that metabolism happens in the liver. There's exceptions all over the place, but most of it happens in the liver. Depending on the drug, sometimes it's a multi-step process. And the very long and short of it is the molecule is manipulated by various enzymes in the body to make it more polar, typically, so that it can be excreted in the urine. That's how most drug metabolism happens and excretion happens. There are drugs that are excreted more through the stool. Some of them are completely metabolized into biomolecules in the body, and then they're used for whatever else, or used as building blocks for anything. Pretty much, they can be turned into amino acids or fats or whatever else.
Right. The body's a good recycler, right?
It's very good. So that's the very high level view of metabolism in the body. Yep, go ahead.
Oh, no, you go ahead. You go ahead.
And one of the big things we think about with acetaminophen is extensively metabolized by the liver, and there's kind of two main metabolic pathways. And one pathway is essentially the preferred pathway. It is more likely to be metabolized in that way. And then you have a essentially non-reactive metabolite and everything's hunky-dory. The issue is there's not as much of the enzyme that does that metabolism compared to the enzyme that makes a potentially dangerous metabolite or more dangerous. And the way the biochemistry works, the safe pathway will always happen 90% of the time plus, as long as those enzymes are available. If there's too much acetaminophen, then it kind of spills over into this secondary pathway. And then those metabolites can create oxidative stress and at sufficiently high levels can cause liver injury.
Mm-hmm.
So tell me if this is the way that I've kind of learned, and then this is the way I then teach acetaminophen metabolism, which is like the same story but told with different words. Metabolism is going to vary based on your age, your liver function, your genetics, right? But in a typical healthy adult taking the recommended dose on the bottle, when you take that in, about 2% of it is going to be excreted directly by the kidneys through the urine. About 90%, somewhere in there, will be acted upon by what we call phase 2 enzymes that are in the liver. We've got 6 different pathways that are basically where we take a more friendly compound and add it to whatever that target molecule is that we're trying to eliminate. We bind it to one of these friendly molecules, and then we can excrete it. And the urine, most likely, some might go into the bile, right? So about 90% of what we consume will be basically captured and neutralized through that phase 2 conjugation through glucuronidation or sulfation pathways, where we're just adding a molecule of glucuronic acid or sulfate, binding it, taking care of it, neutralize it. Great. But about 5 to 10% of that dose is going to come into contact with the cytochrome P450 enzyme, which is a different group of enzymes that, instead of conjugating that target molecule with another one to neutralize it, it'll activate it, and it'll make it even more reactive. So that's that reactive intermediate molecule that's getting produced. So 5 to 10% becomes this more toxic compound called NAPK, or the pronunciation of this metabolite, N-acetyl P-benzoquinine amine or something like that. It's NAPK is the acronym.
We've all been reading to ourselves over here, and now we're actually having to pronounce stuff in real
So
life.
this NAPK is the thing that can cause liver toxicity and an overdose. Basically, what you're saying, if you have a large enough dose that those other pathways get overwhelmed, you're going to get more coming through that cytochrome P450 pathway and more of that NAPK toxic intermediate produced. And then that compound requires glutathione in order to be neutralized. Is that your understanding as well? So the relationship with glutathione is really interesting here, because that's where we might see some genetic variation, because all of these enzymes we're talking about, they're all just 3D printed off of our gene code, right? And we all have different genetics, and we might produce some of these enzymes that are more or less effective. Some might be faster, some might be slower. So you might have a slow process of metabolizing these compounds in the first place, but on the flip side of that, you may also be kind of a slow producer of glutathione, or you might produce kind of slow glutathione S transferase enzymes, which are responsible for putting that glutathione on that toxic metabolite to neutralize it. Genetics in that way can make you a lot more susceptible. But I think that, to me, one of the most interesting points here is around this idea that we need this antioxidant to be available in order to mitigate that potential harm, and that there's a chance that some people are more deplete in that, whether it's from nutrient deficiencies, chronic low-level uses of acetaminophen that could be depleting glutathione levels, metabolic issues, environmental exposures, infections, whatever you're sick from. Is that causing high levels of inflammation that's causing more oxidative stress and more depletion of glutathione levels to set this stage for being more susceptible to damage from a slightly larger Tylenol dose? Does that make sense? Is that, I don't know.
Is that like, I feel like so many times, like me and Hannah were talking about ivermectin, and this also we're like, is that right, Bob?
Mm-hmm. No, I mean, that's exactly right.
Man, only if we had some glutathione that we could sell people, I feel like now would be the perfect time. We could just go right to break, sell them the glutathione, get them back, make a ton of money.
I mean, what's interesting about this to me is that, the way to increase glutathione levels as quickly as possible, and Bob, correct me on this if I'm wrong, is through the administration of N-acetylcysteine, because cysteine is the rate-limiting nutrient in the production of glutathione. And so what's interesting to me is that NAC is safe to take in pregnancy.
That's I didn't know that. That's interesting. I almost called you Hannah, Amanda. I'm sorry.
Acha!
Okay, yeah. So NAC is, Bob, just FYI, we give people, clinically, when I was practicing, NAC was indicated sometimes for our clients. Nutritionally, we would use it as a supplement. I don't know what the effectiveness is as a supplement versus like they give it intravenously, right? Like if you've had an acetaminophen overdose.
Yeah, it's one of the treatment options for acetaminophen toxicity and also liver injury and severe liver disease in general. So if a patient is having like acute hepatic failure, we can use that to kind of at least partially walk it back.
Slow it down.
And whenever we're using acetylcysteine for either case, the patient will typically receive it for 24 to 72 hours, depending on how they respond to it.
Wow. But I wonder, so this might be, though, to be extremely clear, we don't have a legal team, but we are not giving you medical advice.
Yeah.
But would it possibly be if a woman is pregnant and she needs to take Tylenol to reduce a fever, or, I keep thinking it's to take a tepid water bath, or, I'm sure, and I do not know, I'm not an herbalist, there are some herbs that could be used in pregnancy for pain or like that, but that if Tylenol is her best option, she could also get an NAC as a supplement and take it. Could that partially mitigate some of the potential risk? If there is potential risk, which is still a big question mark based on the studies we have.
I think it would depend on the individual woman and her metabolic enzymatic status overall. How, depending on how her enzymes are expressed and how active they are, would influence how likely it is to develop Tylenol toxicity. That would be something that you would have to look at on a patient-by-patient basis. Just not a very satisfying answer for me to say it depends.
No, that's why
here, actually, and it's why I wish you were at that press conference.
Yeah.
And it's the whole point of this is to show people, this is one of the meta reasons that this podcast exists, and it's not super sexy, but we can't just say, X plus Z equals Y. I don't know, whatever analogy. What's the saying? It's not black and white. This is not black and white. We're dealing with extremely complicated biochemistry sets that happen to have emotions and urges
And a big part of why I was bringing up that point was to say there's likely a lot of individual variation on these really subtle levels of what is your antioxidant status going into the administration of this drug? What is your genetic metabolic capacity? And that there's so many different things that could explain why the data are not more just conclusive.
Yeah.
But then to finish answering the question, in terms of would acetylcysteine supplements help reduce the toxicity, ideally we wouldn't be getting to toxic levels to begin with.
Yeah.
So it's kind of what are we doing if we're getting into this position to begin with? If we're concerned about the toxicity at the dose we're giving it, we should probably not be doing that to begin with.
Uh-huh.
One of the big things that I always push for is not prescribing a medication to treat a side effect of another one. You go to the source
Uh-huh.
and you change that.
And we can take the same prescriptive mentality with supplements.
Oh my God.
Even
yeah,
though
I mean,
it's,
that's-
yeah. Yeah. I did some research on N-acetylcysteine, and I was curious to know whether, if it is helping with the metabolism, would it potentially clear it fast and reduce the analgesic quality? But it doesn't. And in some studies, it actually shows that it might increase the analgesic property of Tylenol. And I guess that makes sense
Nice.
because it's really just primarily dealing with that NAP key. It's kind of more downstream from the analgesic effect.
And then whatever else it's like, I'm sure that cysteine can contribute to other processes in the body that may need that amino acid. I wonder if there are other mechanisms that it's supporting,
Absolutely.
Yeah.
Yeah. So something that comes up actually, I forgot to say this. People hear us talking about these metabolic pathways or like that. More commonly, people hear these in the realm of like detox culture, where it's like you're going to detoxify and you're going to support like your phase 1 and your phase 2 pathways. It's like those are pathways that absolutely exist. Your body uses them, at every moment of every day to get rid of all of the different compounds that you intake, including hormones, which is an important one. When you ever have sore boobs when you're bleeding or like that, it's like sometimes it can be connected to liver function because those pathways possibly are not clearing estrogen the way that they could. There's so many applications for this, but in this conversation we're talking about, I feel like I keep saying acetaminophen. How are y'all saying it? Acetaminophen? Is that the...
I say acetaminophen, I say acetaminophen.
Okay.
When I'm writing it in the medical context, they pretty much always put APAP, APAP.
Good, because you know who did not know how to spell acetaminophen until this week? Right here. I was like, I know now, but that is not the easiest word to spell. So do people know we're talking about those pathways? And I think one of the main points to come out of this is we don't have to go through that press conference step by step. But Bob, in your episode on ivermectin, we opened the entire episode. It was the most beautiful quote. Hannah and I were like, oh, thank God, I'm like, if anything ever happens, I'm totally going to where you practice, to have you as my pharmacist. But you were like, basically money and politics do not have a place in medicine. And I feel like a huge part of what is happening right now is that the complication, and we're beautiful in that way, like humans, and the way that we interact with our surroundings, whether it's food or drugs or like that, it's a really like elegant system. It's not something that can be explained in an hour, and it's not something that is going to be solved when problems arise with a warning label on one of the only pain relieving drugs or fever relieving drugs that's safe in pregnancy. And that's a problem. So like a few points that I've thought about this week is, what if a woman does have a fever? Okay, we will put studies in the show notes that show. The one that was most concerning to me was on ADHD. We can link to this, where if a woman gets, in this one study, it was above 101.3, I think was the exact degree Fahrenheit fever, more than twice in the second trimester, the associated risk of ADHD went up 164%. So is that every woman? Absolutely not. But is that a pretty strong association? Yeah, it is. And so in a situation like that, maybe you have tools to keep the fever down that are not Tylenol. Great. That's wonderful if they get the fever down. But if Tylenol is your choice and that's what you know about, I just think about, women who maybe hear that press conference, or they would see the warning label on the bottle and they choose to not treat their fever. And I didn't look, Amanda or Bob, at any studies showing a connection between, let's say, like pain conditions and adverse outcomes. But you bring up a really great point, because it sounds like indicates more chronic use in pregnancy. They're foregoing that option, and then there actually may be worse outcomes when that happens. So I think the messaging and the takeaway and the impact that it'll have on people I mean, individually, but at a population level, it's problematic. So I don't know if there's anything you all want to say about that press conference or the takeaways, to give people a little bit of like ease in their decisions. But to me, that would be a goal of this podcast is, hey, it actually may be the better decision if you have a fever to take the Tylenol.
Absolutely. I mean, we have decades of evidence and data to support the use of Tylenol in pregnancy. And one of the things that I heard a lot in the press conference was take the smallest dose that's effective and for the shortest time possible. And it kind of made me, when I heard that so many times, I was like, well, yeah, we already prescribe it that way.
Mm-hmm.
This isn't a new thing.
I think that's such a huge theme that I'm noticing too, is this kind of stating this cautionary principle as if it's like this new idea. And I wonder where that gets lost, because I can say for myself that I believe the medical guidelines are to use the minimal effective dose as infrequently as possible. That there's a precautionary principle being applied to pregnant people, especially in the guidelines, but that might be getting lost clinically. I know that when I was pregnant, the message was kind of like, don't worry about it. That's safe. It's safe. Go for it. Right. There wasn't that communication of like, yeah, use it as when you really need it, but try to manage with other things first. And so, I do think there has been maybe a little bit too liberal of a license to say, okay, this is safe, done, conversation over. I'm going to use it for all my aches and pains. Like, I think that is maybe in the public somewhere, but that's not coming from the highest level of medical guidelines. I don't know, where does that static get brought into the line? I don't know.
It kind of reminds me, honestly, of like dietary guidelines. When you actually look at my plate, it's fabulous.
Yeah, it's like
fabulous. It's like most of your plate should be fruits and vegetables, whole grains, beans and legumes, adequate serving of protein. Okay, maybe I would have the protein be a little bit higher based on the type of research that was done, but like we're total protein nerds, so we've looked at that really close in the context of sports nutrition. Okay, so like maybe that would be a little different. But then they're like, try to avoid sugar sweetened beverages, drink water, right? Like, but then that gets completely turned on its head somewhere along the lines. It's like, yeah, there's static in the line everywhere. I'm glad they're saying that. That's great. But yeah, I can imagine, God, if you've been telling people that, Bob, for, your career, and then you hear it like it's something new, you're like, come on.
Right, exactly.
Yeah.
Well, so I want to say that I did read that 2021 consensus statement urging for cautionary approach, arguing that there wasn't sufficient, data, that we needed to revisit, the recommendations and guidelines. I felt like a lot of the mechanistic information was concerning, a lot of animal studies that were concerning, some potential neurological effects, even at hepatotoxic doses. So I don't know, do you want to speak to that at all? I mean, I know there's an important conversation to be had about the difference between mechanistic studies and outcome-based studies. And at the same time, a lot of what we eventually learn in medicine starts with mechanistic studies. They are also valid, just like observational data is valid. We just have to interpret it for what it is with its strengths and limitations. But I do think that some of the mechanistic research on it is you can see how it can give reasonable people concern.
Absolutely. And I read through that study as well, or that
consensus statement.
And then I looked through several of the cited studies in it. And I think the idea of paying attention and doing more research is good. I think that some of the studies cited don't necessarily support the urgency / alarm level that we hear in the media. Because some of these animal studies are using very high doses, and a lot of times in animal studies, we do that. We dose much more than we would in a person, because we want to see that safety data of kind of how much is too much. And we don't want to go to people and say, take another pill until something bad happens.
Right.
Yeah. And what would we be looking for when we got to too much? What would happen?
Right.
Yeah.
So a lot of those studies are at very high doses. In adults, the recommended daily limit for over-the-counter Tylenol is 3,000 milligrams a day, and prescription level is 4,000 a day. And that works out to be around like 40 to 60 milligrams per kilogram, depending on how big the person is. In some of these animal studies, they were using 200 milligrams per kilogram daily.
So more than double.
It's the equivalent of if we were giving a person a half a bottle of Tylenol every single day.
Yeah. We see this all the time in nutrition research. Where, people are like, oh my gosh, stevia is going to cause me to go, cause infertility. Look at this study, and it's a mouse study, and they're eating, like half their body weight in stevia.
Yeah.
Yeah.
And I would say, I'm not dismissing all of the data out of hand. I did look and see which ones I said, yeah, I agree with that. Yeah, that one, I'm less confident in the implications. And not all of those cited studies met statistical significance, or only certain markers met statistical significance. So they're not all just outright supporting every single claim that certain aspects of the media repeat, if that makes sense.
Yeah. And, this goes back to what I was saying earlier, is it feels like kind of both sides of the debate are saying a similar thing, which is, if you read the ACOG rebuttal to that consensus statement, it points out a lot of the limitations in the data that are now being used to say this is why we shouldn't use it. They're saying this is why we shouldn't take this necessary needed medical treatment option away from patients. So it's just interesting to see how the same limitations can be used to argue either side of a debate. I thought it was some of the really interesting limitations. Again, we see this in nutrition research all the time, especially with mechanistic studies and with animal studies, where they use exposure levels that are super physiologic, nothing you would ever encounter in normal day-to-day use. We also see this issue that plagues nutritional research, which is how dietary intake is reported. And that seems to be another issue with a lot of these acetaminophen studies, is that they're not all looking at the same measurement. They're not all taking actual biomarkers, like looking at acetaminophen levels in the blood to verify exposure rates. A lot of them are relying on reporting to their OBGYN. And one of the studies that are looked at as one of the strongest studies in favor of upholding the safety of acetaminophen in pregnancy is Alquist, the Swedish study that was the sibling pairs, the 2.5 million children. So that was, that's been cited a lot for people on that side of the argument that it is safe. In that new 2025, was it a meta-analysis that came out?
It's actually a systematic review.
Okay, so they had some interesting comments about that Swedish Alquist study about the reporting being done through visits to the midwife, where they simply asked patients to tell them what medications they were taking, but weren't directly asked about acetaminophen. The issue being that about 7% of patients were reporting acetaminophen use, which is completely incongruent with a lot of other studies that actually do more the higher levels of monitoring that find that population-wide the acetaminophen use rate was closer to 50%. I'm probably butchering those numbers a little bit. I don't have them up in front of me, but just the idea that maybe reporting is a major confounding factor in a lot of this research.
Absolutely. One of our big things in pharmacy is when we're doing a medication reconciliation, where we're asking the patient, what medications do you take? A lot of patients only think if it's only a medication if there's a prescription involved.
Right.
And
yeah. Right.
And they just don't have this like mental same category for over-the-counter medications. So we go through all the medications, and then as part of the interview process, you say, "Do you, what do you take over the counter or without a prescription?" And then
Yeah.
a lot of them say, "Oh yeah, I take this and that and the other thing."
Yeah.
And so we have to form our questions in a constructive way that helps us, get that reporting to be more accurate.
Yeah, that's, I mean, a whole skill that you learn in nutritional interviewing is like how to ask a question the right way so you can get the most accurate answer. I can imagine, I mean, it's the same in a pharmacology interview. I mean, that I read that it's the 2025 study evaluation of the evidence on acetaminophen use in neurodevelopmental disorders using the navigation guide
Mhm.
methodology. I think it's like the
Mhm.
most recent study that's been cited.
Yeah.
And actually, one of the biggest lines I pulled it out that stood out to me is they wrote, because the included studies were all so different, it had substantial heterogeneity is the way that they put it. That's why it's not a meta-analysis. They did do a
Oh.
systematic review, but
Mhm.
they opted for a qualitative synthesis. So just for people listening, and Bob, as always, we're going to defer to you, Bob. I feel like you got like the chops here, but it's it can be a little bit less strict as far as how the data is pulled, and the stats aren't as analyzed as they would be in a meta-analysis, because the studies that they included in this big review of all these different studies, the reporting methods were different, the exactly what they were looking at was different. And so even though 46 studies were included, these were the findings. 27 studies showed a positive association between acetaminophen and neurodevelopmental delays. 9 showed no link. And then 4 actually showed, and we never talk about this, but 4 of the studies included in this review showed positive associations, meaning protective effects of acetaminophen in pregnancy for
Or
neurodevelopmental delays. It's like,
negative associations.
yeah,
It's this weird thing where in statistics and correlations, positive means they go together, negative means they go apart. So we can say positive association between drug and negative outcome, even though it's a bad thing, it's still a positive
Right.
association because they go together.
yeah, it's right. So if we said it in a way that was a little bit more logical, it's like 27 studies reported like maybe there's a problem. 9 studies showed we have no idea. It's just kind of nothing. And then 4 studies were like it's actually protective
And
against
then
neurodevelopmental.
whether or not they are able to go in and adjust for confounding factors is another huge deal. And there's all these, you just can't say it enough that observational data and the fact that we can draw associations between everything. What is it, like ice cream and shark attacks? Well, they both are happening more often in the summer because you're on the beach. Idea is so important for people to understand that you cannot prove causation with observational data. And the idea there is, well, maybe we see this link, but maybe there was something else going on in the health of that mother that caused her to take Tylenol that may be more related. Maybe, was it the underlying fever that she was finally taking the Tylenol for? Was it some other inflammatory condition that, was causing aches and pains? What, any number of healthy user bias there? Was it somebody who, is paying super, tight attention to her health during pregnancy and preconception and is taking all her prenatal everything, and she's avoiding Tylenol because she's so, so cognizant of fetal health versus other populations that are just generally not doing 100 other things for fetal health. And oh, by the way, they're taking more Tylenol. Like there's so many potential confounding factors in this research.
Right. A 9-month pregnancy is about 250 days. So there's 250 days that this thing may or may not factor into, first birthday.
Yeah, and then that the fourth trimester where the brain is still in a critical developmental window that also we have all sorts of potential exposures. I mean, it's just, I think this is important in terms of like rolling back the conspiratorial mindset around all of this. It's not like we're trying to hide researchers are trying to hide data or, give you the poison or whatever. It's like, this is really hard stuff. We don't go in and open fetal brains and like watch, this is extremely difficult stuff to study. So I think with that, it helps me just feel a little bit more like, look, we're all on the same team. We're trying to figure this out.
And also, not for nothing, if you ask any of us nerd asses to talk to you about this, you're going to wish that you didn't, because we're going to be like, how long do you have?
Eyes
We will
rolling.
tell you everything that we know. Like, we email frequently the authors of papers and we've had some great success of people getting back to us or, giving us a quote for the podcast or coming on the podcast. And sometimes we're like, wow, they emailed us back like 2 minutes later, because they're just like, somebody read my paper and I get to talk to them about it. So yeah, I think the conspiratorial piece is concerning to me, but mainly I just think about these women who are like,
scary.
What do I do now? And again, to come back to like, I hope you hear this and you feel less afraid. The reason that we're kind of pushing against you see this in headlines where I saw this, I need to get off social media, but see this on social media where people are like, oh, in the past, there's been reports about the possible harms of Tylenol in pregnancy. And it's like, yes, good. We need to report on that. And then, the same outlet is reporting on like, there's this causal relationship between acetaminophen and autism, but maybe the science doesn't support that. It's like, yes, that's also true. It's like, I am actually no fan of the media by and large, to be perfectly clear. And I'm certainly no fan of politics, but I am a huge fan of people doing science, much more than I am of corporations doing science, but I'm a huge fan of scientists. And I feel like more than not, the research that is done is in good faith. People have done their absolute best. It's their passion. It's their career. We don't get paid a lot of money in that field. There's a reason I'm a marketer and not an academic writer. It's like, to have some like, I wish that could, maybe what I could say is I wish that could be better conveyed in a press conference, but that's not what's being conveyed. Just in your talking about confounding, Amanda, I pulled all these out. It's like infection, fever, migraine, pain from autoimmune disease, parental health and genetics. We know that people who used acetaminophen during pregnancy reported higher prevalence of other health conditions that are associated with neurodevelopmental disorders, other medications. There's all of these confounders that I didn't hear those mentioned once.
Yeah. And I think it's like back to what you were saying, Bob, the recommendation has always been to take a, minimum effective dose when you really need it and try to minimize frequency. That's the recommendation for any, like, pretty much any medication, right? Unless you're talking about like thyroid hormone or something, or blood pressure medication in pregnancy. But I think that your point of there are 280 days of gestation, and then there's also a critical window of development immediately after birth. Focus on that. Like, if you've taken some acetaminophen, know that it's not conclusive entirely, but we do have decades and decades. There have been millions and millions and millions of babies born to mothers who took acetaminophen who are neurologically normal and healthy. You could very well be one of those. And to focus on the rest of whatever 280 days you have in your pregnancy, and like managing stress is a big piece of that, finding internal calm as much as possible, and thinking about the other ways that you can do things like get a good diet and exercise and manage your stress, and focus on your sleep, focus on what you can do. There are still so many other things that are associated with neurodevelopmental disorders that are modifiable, that you can continue to pay attention to and do your best to mitigate. Like, this is one tiny piece of the picture of your total pregnancy. Tiny. There are so many other things that you can feel more empowered around.
Yes. Any final thoughts, Bob?
Nothing really comes to mind. I mean, you pretty much hit it on the head, Amanda. It's a marathon. And there's so many little things that could affect it. It's irresponsible to point at Tylenol without looking at doing thorough and well-designed studies on it.